who will be addressing us on progress and breakthroughs in modern orthodontics. We warmly welcome Dr. Pratibha ma'am and invite her to deliver the first lecture of the day.
Good morning, everyone present here. Thank you for the warm introduction talk. So, first of all, I would like to thank the organizing team and Principal Sir and Dr. Ivan for creating such event and inviting me for this lecture. So, my topic that was given today for me was progress and breakthrough in modern orthodontics. So let's go into the topic. So by the end of this lecture, so the goal is you will be able to connect the milestones from the orthodontic history to the digital era and to describe end-to-end digital workflow from how we take records, how we plan digitally, we plan and then we fabricate appliances and to identify the key tools that is being used in digital orthodontics, starting with your intraoral scanner, CBCT, cephalometrics, CAD-CAM, and 3D printing. And the goal is actually very practical, what tools exist and what they are good at and how to adopt them safely. So why this topic now? Why there is a shift to digital orthodontics? So this digital transformation is not a future concept. It is actually a current standard for enhancing the predictability and efficiency. So these records are actually faster to acquire, easier to store and easier to share. Just like how how do you share your impressions and your digital casts? So this and the patient's expectations are also changing. The patients tend to demand with more comfort, aesthetics and fewer visits. So which remote monitoring can support that can be helpful with your digital orthodontics. So okay, a short question for you. So how long do you think braces have existed or something like braces like devices have existed? What do you think? Option A, B, C or D? Is it 50 to 100 years or 200 to 300 years or 500 to 1000 years or more than 2000 years? Something like braces like devices, when does it exist? How many of you are saying B? A? C? B? Okay. So I'll give you a clue. So this is the first type of braces that was found. Something wrapped onto the teeth. Okay. So now, yeah, mummies. So the option, correct answer was more than 2000 years ago. The archaeological evidence suggests they found something wrapping around the teeth. It is like a catgut material, okay? It was wrapped around the teeth to straighten the teeth. So the Egyptians were the first one to, who tried to make the, straighten the teeth, right? So we'll go to a short history. I'm not going to go into a detailed history, but if you have to understand what is modern orthodontics now, you should know about from where we have evolved, right? So this is started 2000 years ago from Egyptians, Greeks and Romans. And Romans, what they tried, how to align the teeth, they want a straight teeth, okay, but they didn't know how to do it. So they used to push their teeth. They used to give finger pressure to straighten the teeth. That was the technique that was followed then. And the initial techniques, they were alongside, it was mechanical and it was very often crude. They used very tough materials and they even used noble metals like gold to straighten the teeth. And this was the material that I was telling you, catgut. What is catgut? Any ideas? It is even used nowadays by surgery, yes, yes. Why is it called as catgut? Gut. So it is derived from? Is it derived from cat? No, it is not derived from cat. Good. It is derived from either the cattle or sheep, right? Okay. So There were from the ancient history, then we will, the major revolutionary changes in orthodontics happened when, because of this pioneer in dentistry. Can you guess this person? Who is he? Any guesses? Okay, he would like to say hello to you.
I trust this message finds you well. It is a distinct pleasure to make your acquaintance today. I extend my warmest regards and a most cordial welcome.
He is the father of modern dentistry, Pierre Faucher. Have you heard of his name? Yes, he did some revolutionary changes in the 17th century, both in the field of orthodontics and also in the field of dentistry. So he was the person who developed this first type of appliance called as bandu. So this appliance was given, it will look like your oral screen. You fabricate oral screen, right? You would have seen oral screen. So it is a it is a rigid band. It is made of either gold or silver, and it has multiple holes. It is fitted with ligatures like silks or threads to hold the teeth to the appliance. So the problem was this was very uncomfortable for the patient, and it was expensive because it is made of gold or silver, and it is not widely accepted at that time. And then many pioneers in dentistry came up with many modifications. You know who is the father of orthodontics? Father of orthodontics? Okay. Norman Kingsley, he came up with the thought of jumping the bite. He developed many extraoral appliances to correct the jaw deformities and everything. So let's move forward to 20th century. Okay, I don't want to bore you with your history. So can you guess this person at least? What is his contribution? You are following his classification of malocclusion. Yes, he is Angle. So he is the father of modern orthodontics. He is Dr. Edward Hartley Angle. So this is the era when orthodontics became a structured specialty. Before then it was just a dentistry. So this is a time where it became a structured specialty. So they brought innovation in orthodontic appliances, moving from bulky external appliances to an innovative intraoral mechanics. So these are the appliances that was developed by Angle, like E-arch, ribbon arch, and this is your edgewise appliance. So this edgewise appliance, it formed the basis of your contemporary orthodontics that even we follow now, right? And there was, since then, there was evolution of bracket systems. The early fixed appliances, this was the early fixed appliances. These were heavy bands that were fitted onto the teeth, requiring extensive laboratory work and chairside time, and it was uncomfortable for the patient. And then there was evolution of single width brackets, twin brackets, Lewis brackets, universal brackets, and then the development of your straight wire appliances. And can you identify these appliances, some of which we are using now? Yeah, self-ligating brackets where you don't need to add extra elastics, and this is lingual brackets, and then your clear aligner bracket systems. Okay, so you know how orthodontics has evolved from your catgut material to your bracket system now. So what is the problem with now your conventional diagnosis process? So in conventional technique, what do? We actually first, when the patient comes to your department or your clinic, for the patient, you will be taking the first age, you will be taking your history, like case history. You will be examining the patient, you will be finding the chief complaint, medical history, everything. And then you will be finding the observations, your extraoral, intraoral, your clinical examination, everything you will be doing, and then you will be diagnosing the problem, like how you diagnose Angle's class 1 skeletal malocclusion with the horizontal growth pattern and so on. And then you will finally derive into your treatment plan. Treatment plan depending upon the problem. Either you have to go for an extraction, non-extraction, or a surgical option, and then mechanotherapy depending on the problem. Either you will be going for your fixed or removable or growth modification, functional appliance, orthopedic appliance, etc., etc. And there is an outcome. But this conventional going forward flow is process starts from a patient and then it ends with an outcome. There is no feedback loop that is present. Okay, there is only it is just in one way. Okay, whereas I'll go into your digital. And traditional orthodontics actually works, but it has some limitations. For example, have you faced any difficulty in your traditional orthodontics? Okay, let's take into diagnosis and treatment planning. In the diagnosis, while taking records, have you faced any difficulty? No. Okay, you have faced any difficulty while taking impressions? pouring the cast and preserving the cast without breaking it and without losing it. There are some difficulties, and if you have to transfer it, or if you have to send it to a lab, or if you have to interdisciplinary approach, then there is some difficulty with the traditional approach. And then some repeated impressions, distortions in the impressions. There are so many limitations that is there in your traditional, which we want to correct in your digital orthodontics. So, and the traditional appliances it is not customized to patient to patient. It is based on one size fits all. For example, one bracket system we will be doing for the same bracket system for all patients, right? But we have to do chair side modifications in the wire bending and extra biomechanical aspects to fit into that patient. And it requires frequent adjustments every 4 weeks. The patient has to come 3 weeks, but nowadays the patient is not willing to see you every 3 weeks. Unless otherwise you are in a very friendly relationship with the patient doesn't want to see you every 3 weeks. So these were the problems. So the progress, the need for progress, the progress happened because problems needed solutions, like increased chair side time and your time consuming records, remakes, and there is variations in the bracket positioning. So there is inconsistent lapses. This all needed a progress for to shift towards your digital orthodontics. So coming on to the digital orthodontics, it is not one mission, it is a workflow. Okay? So this is an approach that utilizes advanced digital technologies to diagnose, plan and execute orthodontic treatments more efficiently and accurately than traditional methods. So with the integration of digital devices like your 3D scanners, CAD-CAM aligners, printing that we will be seeing in one by one, we can give a transformative way to deliver care, improving both the patient and practitioner's experience. So this is the flowchart of 3D diagnosis process where you have the feedback mechanism, outcome to patient. So here also when the patient comes, you will be taking the chief complaint, medical history and all. After initial assessment, you will be going for diagnostic data. Diagnostic data, you will be taking intraoral scans, you will be taking the measurements of your teeth, gums, your skeletal measurements, your everything. And after that, you will be coming on with your problem list and you will be going for diagnosis and differential diagnosis. Then you will be going for an option of your preferred treatment plan, and you will have an alternative plan also, and there is an outcome. And this will go into the feedback to the patient and for reassessment, which is not available in your conventional process. Okay? So now coming on to your digital records. So we have seen what is how bracket systems and how orthodontics has evolved, and why is there a need for digital orthodontics. And now coming on to sections of digital records. So this section focuses on the digital records, like to how to capture accurate and 3D shareable data for you to access the patient information. So how many of you have experienced this difficulty while taking impressions for an uncooperative patient? Many of you, right? And you will have a repeated impressions, your guide will not approve, your staff will not approve, and you have to take repeated impressions and you have to convince the patient for that also, right? So there is so you can witness the transformation from the uncomfortable impression trace to your uncomfortable, fast and accurate digital scanning. This is a game changer for both the practitioners and the patients, and for also the staffs, right? So the next session is about your, in detail about your intraoral scanner, so I am not going into detail. Let's move on to the next digital record. Okay. Have you ever seen someone like this in ortho department or prostho department? Or have you seen yourself like this? Yes? Yeah, I have seen on all my PG batchmates, and especially during the first year of PG, after pouring so many casts and bases for those casts, we literally look like this. Okay? So in order to prevent that, you can go for your digital cast. So this is your maxillary and mandibular digital working models. So the recording of the patient occlusion can be done directly with your intraoral scanner, and also by your CBCT images, like your cone beam computed tomography. So when comparing your digital models and plaster cast, both represent dentition, but their practical behavior is actually different. So their plaster casts are something physical. You need some space to store it, and it can break, and it is hard to share, If you have to share it to a laboratory, or if you have to share for to a consultant or to a surgeon, then you have to wrap it and you have to share it. You need some effort to do it. Whereas digital models are easy to store, they are and easy to duplicate, and it is easy to share for communications and consultations or lab fabrications. And they also allow rapid measurements, like you would have done your model analysis, right? Have you done any model analysis in your UG? Bolton's analysis, you would have studied, right? Bolton's small analysis, yeah. So this is all easy when you digitalize your cast, and it is highly accurate. But accuracy actually depends on the scanning protocols also. If your scanning is not good, then the accuracy will not be good. Okay. And these are various scanners that has been used. It will be dealt in detail. Okay. So in the digital record section, now you have taken impressions. You have found the replacement for impressions, and then you have found the impressions for models. Now you have the records. Is that enough for diagnosis and treatment planning? Do you need anything else? The patient's concern is nowadays is mostly towards aesthetics, right? Aesthetics means the patient is not concerned about your class 1 molar or class 1 canine, overjet, overbite. Patient is concerned about the smile and the extraoral aesthetics. So you need to facial scans, and this is for facial scans and photogrammetry. They capture the soft tissue information, just like how we take photographs, right? Extraoral photographs, like. So this will capture the soft tissue information, like to assess your facial symmetry. You understand what is facial symmetry? The proportions of the face on the both is right and left side, and lip posture, smile arc, aesthetic goals, which are all important for the satisfaction of the patient. And also it helps in the data fusion. Finally, when you fuse, you have to create a virtual patient. Virtual patient means you have to fuse whatever the records you have taken, you have to fuse it into a virtual patient. For that you need this facial scans. But it is not indicated for all patients. The patients requiring changes in the profile, patients requiring more aesthetic goals and surgical demands, for those patients this is required. And the next record is your CBCT. It provides your volumetric imaging. Whereas your intraoral scanner is just a surface scan, whereas CBCT, it requires volumetric imaging bone to bone. So that helps visualize the bone and the complex anatomy. This is also not indicated for all patients. It is indicated in 3D assessment, especially patients with any impacted teeth, any pathological morphologies, and any supernumerary teeth root resorption. And in case of TMJ morphology, and to assess the airway volume, and when you are planning for surgical orthodontics and temporary anchorage device. Have you heard of mini implants, temporary anchorage device? Yeah. So to know the exact location of placement of tats or mini implants, you can use your CBCT. So just an example, like this first upper image shows your hard and soft tissue imaging, right side imaging to visualize it. And this is your imaging using your Dolphin, it is a software, Dolphin imaging software, and this is in vivo imaging software to visualize the patient and the soft tissue and the hard tissue. I was mentioning the CBCT can be used to assess your airway volume. So the top picture shows the measurements of an airway where the patient has a restricted airway volume, and this is a patient of obstructive sleep apnea. So this is after treatment you can assess, so we can appreciate the amount of change in the airway volume before and after. This can be done with your CBCT, which is not possible with your 2D. But CBCT involves radiation exposure, as you know. So you have to follow your ALARA. What is ALARA? Yes. So you should be practical, means you have to justify the scan, where it has to be taken, the field of view, and you have to optimize the exposure settings as well, and avoid repeated scans. Okay. And this is the final thing in your collecting data, digital data. So the human face is actually capable of making minute expressions, okay? Because the expression what I make will not be able to make, you will not be able to make. So each one has a peculiar micro expression that is individualized to each patient. So that can be recorded with this facial, 4D facial dynamics, and Specifically, this is also not indicated for all patients. Patients requiring smile transformation or aesthetic reasons, we can go for this digital scan. And finally, this is the data fusion. Data fusion is, now we have collected so many data, we have to fuse it. Just like how you do your case presentation after collecting your cast, your impressions, your cast, base former, your photographs, you will analyze and then you will present the case. Like that, now we are fusing the data, whatever we have got it, and you will be making a virtual patient. So this is just an example how the data is fused, I am telling you. This is a patient who required surgery. So the patient is having maxillary retrognathism, mandibular prognathism, and the pre-surgical orthodontics have been done already. Now the patient has to plan for surgical option. So the CBCT of that patient with field of setting, proper field of setting, to capture the vital information that is required for the virtual surgical planning. Okay. So these two dots, they represent the glabella and the neck throat point. And this is the digital scans that was obtained for that patient, this Jill cast. And this is the CBCT, second B is the CBCT image that was got. And this third is the integrated CBCT image with the dental cast. Can you appreciate it? The dental cast, digital cast, CBCT and the integrated CBCT image. So this is the 3D facial 3D tissue scan with the true color depiction. This is and then the second is the CBCT image, and the third is your integration of your CBCT with the facial scan and the integration of the. And you have some reference points, landmark points for this orientation for integration. And this is the integration of the 3D photo to the soft tissue skin. And this is the final virtual patient that is ready for your virtual surgical treatment planning. Okay. So now you can plan the treatment whatever you want, like that you have to discuss with the surgical team and orthodontic specialist. They will be discussing what surgery has to be done for the maxilla mandible. The surgical planning will be decided, and the outcome also, as you can see, the first upper picture shows the pre, and the post is the C and D are the post pictures. So you can appreciate how much amount of maxilla will be brought forward, and mandibular surgery and genioplasty has been planned. So this will be easy for the for communicating to the patient. You can tell the patient this is how you will be looking after the surgical procedure. So it is easy to convince the patient also for surgical or any other orthodontic procedure. So this is the post-treatment radiographs of this patient, photographs of the patient. So this is how the digital records have been taken, and that has been fused, made a virtual patient that can be used for multiple purposes. Okay. So now moving forward to your digital analysis. Now so you have your records. Now the records are just your, it is just what we capture. So now we have to go for your analysis. What analysis do you usually do in your conventional orthodontics? Model analysis you will do, right? You will be taking casts, sometimes you will be more. Cephalometric analysis have you done? Any, or you would have, in your theoretical aspects it's there, no? Tweets analysis, Downs, Steiners, you would have right. Yeah, Tweets triangle and all you'll be. What is the purpose of Tweets triangle? To know the position of your lower incisor, mandibular plane angle, and so and so. How many of you like to do the cephalometric tracing? Not, only one. Okay, good. So this cephalometrics has also evolved from manual tracing to software-based tracing. So it is also being digitalized. The advantage is not only speed, okay, it is also reproducibility, and it is easier to store, and the ability to compare changes over time. Because in orthodontics, the problem is the treatment time. We will be taking at least more than 1 year to complete a treatment, and complex cases 2 years. So mid-treatment we will be taking some records, pre-debond we will be taking some records. So everything you have to compare with the pre-treatment your cephalograms. So this digitalization of scans, digitalization of your radiographs is actually easier, and when you have when you are handling multiple patients, this is more convenient. And there is automated landmarking will be there. You need not go and search for chorion, nasion, or orbital. So there is automated landmarking, but that should be verified by the clinician or the doctor. Okay, sometimes the error might come. Okay, And there is a template. If you have to just click your steerness analysis, the analysis will be done. Tweets, it will be done. Once you have marked your landmarks correctly, then this template analysis, it will be easy for you. And for superimposition, especially for surgical planning or your complex cases, it is actually very difficult, convenient with your digital superimposition. Okay. And one of the common mistakes in learning orthodontics is treating measurements as absolute truth. Cephalometrics gives you values. It will have normal values and you'll know which is not normal. But you have to consider the other factors as well. Some patients, they might not have normal values, like they might not have normal inclination of the teeth or normal position of maxilla mandible, but the aesthetic wise or soft tissue wise, their smile, attractiveness wise, everything will be good. So you need not go for that patient to correct the teeth and position of, unless otherwise the function aesthetic goals are obtained, then you need not worry about the values. So you have to consider other factors as well when you are considering your cephalometric values. Okay, so these, you have taken the files, you have taken so there is, you need file exchange between your scanners and your imaging devices and softwares to analyze the data, right? So these are the two data, like surface data, volumetric data. Surface data is what we took in your intraoral scanner. Okay, it will record just the surface details that is stored in this is STL format. You would have heard of these terms, and in the digital it is the most commonly used, that's why I wanted to mention. So STL is standard tessellation language. It is used to store your surface data. And whereas volumetric data, that is your CBCT, it can be stored in a DICOM format, that is your digital imaging communication in medicine. Okay, these are the formats that is being stored and transferred. Okay, now we have taken the records, we know analysis, what to be done, and we will go for now planning, like your treatment planning and simulation. So treatment, in treatment planning, in conventional orthodontics, we just have to say, if we do this treatment, your teeth will come into your proper position. That's all we can say. We won't be able to simulate them, or we will not be able to show them how your treatment will look after 1.5 years or 2 years. Okay. So this is helpful in your virtual treatment setups, where the patient will be able to visualize the treatment outcome even before the start of the treatment. So this, for example, this patient, this wants correction of the teeth. So we can simulate and tell the patient your smile will look like this after the end of the treatment. It is easy to make the easy for the patient communication as such. Okay, and planning can also be done, like this is for so specified tooth movement or any attachments that can be placed on the tooth for specified tooth movement. It is not one size fits for all, right? In digital planning, you can plan for the specific, each patient you will have a specific treatment planning. Like if the teeth wants mesial movement or distal movement, rotation or such corrections can be done for each tooth movement. So for this patient, look at this patient came with a midline diastema, okay? And the patient had a congenitally missing lateral incisors. 2 lateral incisors was missing. So orthodontic treatment was proceeded, but this needed prosthetic involvement also, because there is Bolton's discrepancy, tooth size Ashland discrepancy. The patient was given 3 options, how her smile will look. This is a differential digital smile design. So the patient selected one option, and that is the output of the patient. So this is easy for the patient communication and also for the treatment planning. Next is your CAD-CAM. Have you heard of CAD-CAM? You would have heard, right? Nowadays it's being commonly used in your UG also. So it stands for computer aided design and computer aided manufacturing. It allows 3D images manipulation through computer software and 3D printing of customized devices in different materials. So it, especially in orthodontics, it can include customized bracket kits and lingual orthodontics, lingual brackets, expanders, your palatal expanders, splints, and surgical guides. And during orthodontics surgical planning, we'll be giving splints that can be even planned with your CAD-CAM customized appliances. But it is a powerful, but it should be integrated with the proper digital workflow. The records, whatever your records you are taking, that should be precise enough. The final thing is your manufacturing and delivering. So you have taken the records, you have analyzed this, you have treatment plan. Now the manufacturing and the delivery final part. So for example, if you know direct bonding, indirect bonding, right? What is direct bonding? Direct bonding means you will be directly bonding the brackets onto the teeth. Indirect bonding means we will actually initially itself we will plan, and then we will plan the position of the brackets wherever we have to place, and then we will customize it in a tray, and then we will deliver the tray. Okay, this advantages reduce chair side time, more precise control over the positioning of the bracket. Okay, so this can be applied to your indirect bonding, where you will scan, you will design the bracket placement, and then you will be delivering it to the patient. So that in usual traditional bonding it will take 1 hour of time. This will take just 10 minutes also. Okay, you have to just cure it. And the 3D printing in orthodontics is most visible parts of digital orthodontics. It translates the digital designs into physical items quickly. So we commonly print models, you will print aligners, and for indirect bonding trays, occlusal splints you can be using for your 3D printing in orthodontics. So, and this, the most important aspect of your 3D printing is your aligners. So they transformed orthodontics by offering an aesthetic removable alternative to your fixed appliances. So it is entirely works on the digital workflows from initial scan through final delivery. Any of you wearing aligners? None of you are wearing aligners? No. Sorry, okay. So the complete digital record workflow. So this is the first use end-to-end production pathway. So we start with an intraoral scan, then create or confirm the digital plan, export the file, print the model, and complete the post-processing through washing and post-curing. Then we thermoform the material, trim, finish the appliance, and finally we perform a quality check before delivery. So this is the complete digital workflow of how the aligner is being delivered. And there is latest frontier combines your customized fixed appliances for each patient, lingual appliances, and you have robotic wire bendings that can be done digitally. So when this digital workflow fail, what can cause it to fail? It usually not the concept of digital routing, but inconsistency in the process can fail. Okay, so common problem include inaccurate scans and file handling errors, and any poor occlusal records while measuring or taking scans, and any calibration defects or any contamination. This can go wrong when using your digital planning. So the artificial intelligence in orthodontics is revolutionizing the orthodontic practice by offering advanced analytical capabilities and decision supports. So this helps in your automated analysis. As we were discussing about your cephalometric analysis, everything it is actually helpful, and it is helpful in your treatment simulation. You can even before the treatment starts, you can tell the patient, or you can simulate what is how your tooth going to move from one position to this position, and how is going to reflect on your face. And then you have the AI powered monitoring systems provide an automated alerts for poor hygiene, inadequate aligner tracking, and potential complications including clinical intervention. So compared to conventional, this AI in orthodontics, it supports mainly through your automation and pattern recognition. It can speed up the process of your treatment. It can speed up your digital records, speed up your tracings, speed up your diagnosis part, and it can support your screening task and help and organize your interpret monitoring data. So this treatment is the treatment planning decision to extraction based on deep learning. You can, because of these digital planning, you can have alternative plan which works for the patient. You can plan accordingly, and you can predict the outcome of the treatment by doing your applying AI in your orthodontic practice. And there are numerous researches that is going on in advanced materials and sensors. These smart braces with built-in sensors, they track orthodontic pose in real time, ensuring the precise tooth movement. So it is, even then means from individual to individual, the tooth movement varies. For some persons, it will be completed within 8 months. For some, it will be completing within 12 months. That is because, so that can be sensed with these smart braces. And there are numerous nanotechnology applications in orthodontics. The nanoparticles are being used to develop advanced materials for improved bonding agents, antimicrobial coatings, and more biocompatible and efficient. And then microsensor technology has been used to, it can be embedded in your retainers or aligners to check if the patient is wearing the appliances correctly. Okay, you can check even with your removable appliances. And there is advances in your robotic applications. You have an assistance for your arch wire bending, your surgical. It is all in the research side, but it is all evolving. Okay? And in automated aligner production. So future trends. So looking ahead, we can expect faster manufacturing even in your digital, and improved printing materials, because we have some reported of toxic materials that is all there. So we have improving materials day by day, more integrated AI tools, and better monitoring systems. The technologies such as advanced printing methods, improved biocompatible materials, workflow automation, they may compress the timelines further. So, and then there is personalized medicine integration of your genomic data, bone remodeling markers, and individual biological response patterns to create a truly personalized treatment plan for each patient. And coming to the evidence, a simple way to think about evidence in digital is to separate what is solid from what is still evolving. These digital records, that is your intraoral scanner, your digital cast, that is all well established. So they have strong evidence that supports intraoral scanner reliability and accuracy comparable to polyvinyl siloxane impressions for most full arch orthodontic applications. CBCT is indication based. In only for indicated case, you can use CBCT, not for ALARA because of the radiation exposure. And AA is a powerful time saver, and aligners, the most important aspect is the biomechanics. Not just by the trace, it has to be properly planned with the proper biomechanics by an orthodontist to deliver the aligners. So, if you remember just only 3 things from today, let's be like, first, digital orthodontics is actually a workflow. It is not a machine. So, the workflow must be controlled from the stage 1, starting from with your digital records by taking your intraoral scanner. It should be controlled process. Even when there is some inaccuracy or in 0.01 mm discrepancy in the start of the treatment during a record taking, then there will be discrepancy even at the end, right? And second, inputs determine the outputs. So correct data handling, and it is mandatory. And the AI and automation, actually they assist the clinician, but the orthodontist remains responsible for the diagnosis and treatment planning aspects. Finally, so this artificial intelligence will only be an assistant in orthodontic treatment and will never replace orthodontists. This is actually means like, it is actually for us, as I was telling you, why there is a need. There is a need because their problems needed solutions. So in order to support the need for the patients, we are actually going into these advancements. It is to help the orthodontist or help the practitioner. Okay. Thank you, and gratitude to my teachers. Thank you. Any doubts? So what did you understand from today's session? This session I aim to just to give an introduction about what are the advancements that is available, and it is actually into practice for being even if after your BDS, if you're going to be a PG, you're going to do MDS or being a general practice, you need these updates to have an effective clinical practice in your life. Okay, thank you.
We sincerely thank you, Dr. Pradibha ma'am, for your engaging and highly interactive lecture on modern orthodontics. It enriched our knowledge, providing valuable insights into contemporary concepts, evolving technologies, and their practical clinical applications. Thank you, ma'am. We kindly request all participants and speakers to please remain seated. The inauguration ceremony will commence shortly. Before the inauguration, we'll have a short tea break for 10 minutes. So kindly help yourselves. The refreshments are outside on your right. I request everyone to be seated. We'll start the inauguration in another 5 minutes. Please maintain silence. Good morning, everyone, and a warm welcome to Asan Memorial Dental College and Hospital. We are truly delighted to have each one of you here today. Today's program is designed to inform, inspire, and spark meaningful discussions. We have excellent speakers here with us today who bring us valuable knowledge and experience. To begin, I would like to acknowledge and express our sincere appreciation to our esteemed academic director, Dr. Lakshmi Ravi ma'am, HOD of Orthodontics and Dentofacial Orthopedics, for her guidance and support in organizing this event. I would also like to extend my gratitude to our principal, Dr. Ajay Kumar sir, and Vice Principal, Dr. Prabhu sir, as well as our distinguished speakers and each one of you for taking the time to join us today. Let us begin this academic exchange with the blessings and support of the Almighty. I invite Adra CRRI to render the prayer song and seek the blessings of the Almighty for the successful conduct of this program. Thank you, Adra. Please be seated. As a symbol of knowledge, hope, and new beginnings, we now proceed with the ceremonial lighting of the lamp. I kindly request our beloved academic director, Dr. Lakshmi Ravi ma'am, Principal Dr. Ajay Kumar sir, Vice Principal Dr. Prabhu sir, and our esteemed speakers and Dr. Nandita ma'am to light the lamp. We thank our esteemed dignitaries for the auspicious lamp lighting, marking the formal inauguration of today's event. I now invite our respected principal, Dr. Ajay Kumar sir, to deliver the welcome address.
Director Madam, esteemed speakers, respected faculty members, students, participants, good morning to one and all. I'm glad to welcome you all on this Orthodontic Colloquium 2026, organized by the Department of Orthodontics, Asan Memorial Dental College and Hospital. This CD program has been thoughtfully designed to bridge the gap between the foundational knowledge and the rapidly advancing practices in orthodontics. The Colloquium conducted last year was a great success with over 750 students participating from more than 25 colleges all over India. The students also took part in the online competitions. Lectures were delivered by 6 eminent speakers whose insights greatly enriched our academic experiences. Encouraged by the success of the previous edition, we have now planned to conduct this program on a yearly basis. For this year's orthodontic CD program, we are honored to have a Professor Dr. Pradibha R from Sri Venkateswara Dental College, Puducherry, who has already addressed you on progress and breakthroughs in modern orthodontics. We are also delighted to welcome Dr. Muralidharan, Senior Orthodontic Consultant and Director of My Smart Align, who will be conducting a live demonstration on digital orthodontics. I encourage all the students to participate actively today, interact with the speakers, and make most of this valuable academic opportunity. Thank you.
Thank you very much, sir, for the gracious welcome address and for your continued encouragement and support. We now move on to the felicitation of our speakers. I would like to introduce the speakers of our day today. Our first speaker for the day, Dr. Pratibha Ma'am, completed her BDS from Mahatma Gandhi Postgraduate Institute of Dental Sciences, Puducherry, and her MDS from Ragas Dental College and Hospital, Chennai. An eminent academician and distinguished scholar, she has numerous international publications to her credit and possesses skilled proficiency across various aspects of the orthodontic domain. She has also chaired and presented several CDE programs and scientific forums. Currently, ma'am is serving as a professor of Department of Orthodontics in Sri Venkateswara Dental College and Hospital, Puducherry. The next speaker for the day was Dr. Muralidharan Dhanasekaran sir, completed his BDS and MDS from Ragas Dental College and Hospital. He is an expert and specialist in orthodontic aligner treatment. Sir serves as a member of the European Aligner Society, Austria, and has contributed to more than 1,000 orthodontic aligner treatments. He is also the chief orthodontist and key opinion leader for My Smart Align Private Limited, Malaysia, where he has been involved in treatment planning and software design for aligner therapy for the past 8 years. Sir also has several national and international publications to his credit. He formerly served as professor in the Department of Orthodontics at Karpaga Vinayaka Dental College and Hospital, Chengalpet. I would now like to call upon our academic director, Dr. Lakshmi Ravi ma'am, to felicitate the speakers. The first speaker, Dr. Pradipha ma'am. Dr. Muralidharan Dhanasekaran sir. Thank you, ma'am. Now we'll move on to the declaration of the awards. As we come to the end of the event, I would like to call Dr. Ajay sir to give the first prize winners. Paper presentation, session 1. First place, Ashwini RK from Mada Dental College. Second place, Balasurya J from Mada Dental College. Third place, Lokeshwari J from Satyabama Dental College, Chennai. Paper presentation, session 2. Paper presentation, session 2. First place, Meena from Karpaga Vinayaka Dental College. Second place, Shadia Shamin from Assam Memorial Dental College. Third place, Sarvesh Gautam E from Assam Memorial Dental College. The third place is shared by Jemima Aylin from Mada Dental College. I request Dr. Pradibha ma'am to give the next prizes. E-poster presentation, session 1, first place, Baba Yugashri from Assam Memorial Dental College. Shared by Lakshana R from Satyabama Dental College. Second place, Angelina Praisi Varikuti from Siba Dental College. Third place, AVK Ashwika from Assam Memorial Dental College. E-poster presentation, session 2. First place, Sumaya Khatun A from Mada Dental College. Second place, Navadeep P from Satyabama Dental College. Third place, Safaira from Assam Memorial Dental College. Shared by Umar Mufta from Karpaga Vinayaka Dental College. E-poster presentation, session 3. First place, Tanmay Shri from Satyabama Dental College. Second place, Gayatri SJ from Indira Gandhi Institute of Dental Sciences. Third place, Divya Nitisha from MNR Dental College. Session 4, first place, SN Pooja from Assam Memorial Dental College. Second place, Dishani L from Indira Gandhi Institute of Dental Sciences. Third place, Ovia Prabha K from Satyabama Dental College. Session 5 e-poster presentation. First place, Davina Enoch from Ragas Dental College. Shared by Harini D, Ragas Dental College. Second place, Maniratna C from Satyabama Dental College. Shared by Juhi Suhaina from Indira Gandhi Institute of Dental Sciences. Third place, Shakti Priya from Madha Dental College. Shared by Krishna Prabha from Asan Memorial Dental College. Session 6, Best Poster, Jemima Aylin from Madha Dental College. I request Dr. Nandita ma'am to give the prizes. Wire bending, session 1, first place, Keetana from Indira Gandhi Institute of Dental Sciences. Second place, Musfira Parvin from Rajas Dental College. Third place, Subbalakshmi from Indira Gandhi Institute of Dental Sciences. Session 2, first place, Maya from Indira Gandhi Institute of Dental Science. Second place, Ashika T from Indira Gandhi Institute of Dental Science. Third place, Raja Angle from Rajas Dental College. Session 3, Rajsri Harshita from Rajas Dental College. Second place, Harisha from Indira Gandhi Institute of Dental Science. Third place, Amreen Sama from Indira Gandhi Institute of Dental Science. Session 4, first place, Sureha from Rajas Dental College. Second place, Aslin S.U. Barosha from Madha Dental College. Session 5, first place, Shadia Shamim from Asan Memorial Dental College. Second place, Stanley Edward from Rajas Dental College. And third place, Abhishek Juda from Rajas Dental College. I request Dr. Prabhu sir to give the prizes. First place, Adlin M. Jashana from Rajas Dental College. Second place, Niveda Shri from Madha Dental College. Third place, Kavin Kumar from Asan Memorial Dental College. Thank you to all the dignitaries for distributing the prizes. We congratulate all the participants and applaud the award winners for their excellent performance. I now request Dr. Nandita ma'am to deliver the vote of thanks.
Respected Director, Principal, Vice Principal, distinguished speakers and faculty members and students. It is my privilege and honor to propose the vote of thanks today. On behalf of Asan Memorial Dental College and Hospital, we express our sincere gratitude to our distinguished speakers, Professor Dr. Pratibha and Dr. Muralidharan Dhanashekhar, for graciously accepting our invitation despite their ornate schedules. Their valuable insights and expertise in orthodontics have greatly motivated and inspired our undergraduate students. I extend my heartfelt thanks to the management of Asan Memorial Association, Chairperson Mrs. Shamla Jayaprakash, and Joint Secretary Dr. Gautam Babu for their unwavering support. Our special thanks and appreciation to our Director, Professor Dr. Lakshmi Ravi, Organizing Chairman of this colloquium, for her undeterred dedication, leadership, and vision in spearheading this program successfully for the second consecutive year. I take this opportunity to thank our Principal, Professor Dr. Ajay Kumar, Vice Principal Dr. Prabhu, Advisory Committee members Dr. Girija, Dr. Sudhakar, and Dr. Johan Chako for their constant guidance and support. Our sincere appreciation goes to the organizing secretary, Dr. Ivan Clement, along with all the faculty members of the department, Dr. Muruganandam, Dr. Ajit Kumar, Dr. Vasupriyan, and Dr. Shushmita, for their academic leadership, meticulous planning, and mentoring of students. A special thanks to all the student coordinators involved in various portfolios of the event for their dedicated and tireless efforts and teamwork in ensuring the success of this program. On behalf of the organizing team, we thank the judges for their time, expertise, and constructive feedback, and all the participants for their enthusiastic participation, scientific curiosity, and well-presented papers and posters, which truly reflect the spirit of academic excellence and innovation. Finally, I thank all the academic faculty members and students who are present here today for your time, cooperation, and support, which has made this orthodontic colloquium not just meaningful and memorable, but a grand success. I would like to end by quoting Benjamin Franklin: "An investment in knowledge pays the best interest." Thank you once again and have a nice day.
Thank you, ma'am. On behalf of the organizing committee, I would like to extend our heartfelt gratitude to all of you. This year, we were delighted to witness an overwhelming response with over 350 registrations, including general practitioners, orthodontists, undergraduates and postgraduate students, and faculty members from more than 15 dental colleges across South India. As a prelude to the colloquium, we conducted a 3-lane online competition where approximately 257 enthusiastic undergraduate students participated in paper presentation, poster presentation, and creative wire bending events. The scientific committee received a total of 43 paper presentations, 97 e-posters, and 117 creative wire bending entries. We are especially grateful to the jury members of the online competition, and we also thank our eminent speakers for their insightful and engaging lecture, and we will also be having our second lecture in a few minutes. Thank you.
Good afternoon, everyone. So, first of all, I like to thank the management of Asan Dental College, principal, vice principal, MD ma'am, like Dr. Lashmi Raviram, Dr. Ivan for giving this wonderful opportunity. So, today's topic is on digital orthodontics. So, digital dentistry isn't the future, it is the present. In current era, the clinicians who command clinical workflow will lead the profession. Those who don't will be left behind. So digital dentistry integrates various advanced technologies from diagnosis to treatment planning to solutions such as your intraoral scanners, CBCT, CAD/CAM designing, 3D printing, and AI, artificial intelligence. So you are entering this profession at the extraordinary moment. So your responsibility is to master these tools thoughtfully, distinguishing between the hype and the genuine advancement. So welcome to the future of dentistry. So myself, I am Dr. Muralidharan, former professor in Karpanagar Institute of Dental Science, Chief Orthodontics and key opinion leader for My Smart Align Company. So today's topic will be on intraoral scanners. Thanks to Dr. Pratibha, she has enlightened deeply about the digital dentistry, various fields, various appliances, various applications in the field of dentistry along with orthodontics. So my topic will be pertaining to intraoral scanners and its usages in digital orthodontics. So intraoral scanners constitute a significant role in this evolution, and the future is also very promising. So how it significantly differs from the conventional impression technique is, they reduce the chassis time, increased patient acceptance, elimination of physical storage mortgage, and ability to scan the soft and hard tissue intraoral anatomy precisely. So intraoral scanners, one of the most transforming tools in clinical orthodontic practice. So the advent of IOS, that is intraoral scanners, has revolutionized digital orthodontics, replacing the conventional impression by providing high resolution optical scans that offers enhanced precision, reproducibility, and patient acceptance. So before going to the session, I want you to understand what I am going to talk in the further another half an hour or so. So I will play a video in which the patient is undergoing intraoral scanner. So you will have a better understanding of the future topics. So usually the components of intraoral scanner is your handheld camera, that is your scanning head, along with your computer and a software. This scanner is basically iTero from the insulin company. So the main advantage is there is no radiation when compared to the CBCT and CTE thing, the non-invasive and increased patient acceptance. So we'll get a well precised recording of the intraoral structures when you compare with the conventional technique. This high precision is necessary in most of your dental treatments along with your prosthetic work. So basically, it is used in the prosthetic and orthodontic aligner therapy, implants. So as I said earlier, the components are handheld camera, that is your wand. They will tell us a wand, that is the intraoral scanner wand that is used to capture the images intraorally along with the computer and the software. So usually these scannings will be recorded in a format, like you tell, like JPEG format, PDF format. These 3D images are recorded, are stored in a format that is the STL format. Along with that, we will have PLY and OBG format also. So STL images will be stored. Once you scan the images using the scanner, it will be stored in a computer as STL images or format. So STL stands for Standard Tessellation Language. So the basic difference between STL and PLY or OBG formats is STL, it records only the surface structure, that is your shape of your tooth. Whereas PLY and OBG also records your color texture along with your like texture in this, the surface texture also will be recorded in your PLY and OBG. So usually this PLY like format is used for your prosthetic in case of you are going for a smile designing. So where you want to have a color shading in your anteriors, they will go for a PLY format. Whereas in your simulation or like a 3D printing, you will be having that OBG format. So what is the principle regarding intraoral scanners? How does the scanner copies the surface of the tooth? So intraoral scanners functions by capturing the three-dimensional data of the dental arches by optical technologies, that is your structured light or laser projection. So what you have in the capture, that is your handheld camera, is they will project the light, or it may be a structured light or it may be a laser projection also, which is projected onto the tooth surface, that is your dentition. So the reflected light data is processed into point clouds, in the sense like each picture will be projected as a point cloud in X, Y, Z axis. So these point clouds are then stitched, in the sense like they will be triangulated into a mesh form to get a 3D model. This is how your intraoral camera works. So basically, it will appear light on the tooth surface. The light will be projected and it will be captured by the sensor. By calculating the distance between the light source and the sensor, they will be doing a triangulation that is done by your software to get a 3D detailed structure of your intraoral anatomy. That is how you are getting a 3D model. So usually image acquisition will be done by your camera, then image capture and processing will be your software. So once the camera captures the images, it will be transferred to the software. There they undergo triangulation process, that is the stitching. Then it will be converted into a 3D model. The camera captures like around 1000 images per second. That is how it works. So these images are stitched to form a 3D structure. So this is how your intraoral camera works. So there is a basic difference between how the pictures are captured. So in this picture, as you see, there is a light source, that is your camera head. It projects the light to the tooth surface, and there is a sensor at the sideways. It captures the reflected light. This is how the triangulation forms. This is how the images are transferred to the software. So there is a basic difference between this capturing mechanism, that is the distance to object technologies, by different scanner companies. Each company uses their own capturing techniques. So we will be briefly discussing how it is done. So first will be your triangulation technique. So it is basically a triangle formed between your camera tooth surface and the sensor. So this is a triangulation. So this is a triangulation triangulation technique they will call. So once the light from the camera head projects on the tooth surface, it is reflected and is captured by the sensor. Using this triangulation, we will get multiple images which is transferred into the software, and mesh formation will be done, which results in the exact replication of your intraoral structure. That is your 3D model. So usually in triangulation technique, you have three components, that is the light source, surface of the tooth, and the scanner. So in this technique, one of the drawback is once we scan a soft tissue or a saliva contaminated thing, there will be a reflection of light which lead to the distortion of the images. So what we'll do in this technique, we'll use a powder coating. Basically, it is a titanium oxide powder. So we'll coat the surface of the tooth before going to scanning procedure. So the scanners which are used is CEREC. So CEREC scanners are the first scanners that was brought into the market by Sirona. So Sirona was the first company to bring the CEREC scanners basically for the endo restorations. So later on, from that CEREC scanners, they developed for orthodontic purposes. Next is your confocal technique. So the basic difference between this triangulation and confocal technique, in confocal, there will be a very thin ray of laser will be projected on the tooth surface by a pinhole through the camera head. So from the camera, there will be a laser portion through a thin or small hole that is projected to the surface of the tooth. So the sensor will detect only the focused light from the pinhole thing. So unfocused light will be not captured. So the main advantage of confocal technique is there is no need of powder coating, that is your titanium oxide on the tooth surface, because it captures only the focused light into the depth of the surface and is reflected into the sensor. So the confocal technique are used by the current modern scanning companies, that is ITRO, then 3Shape, that is Trios. Then comes your active wavefront sampling. In this technique, what will happen? The camera will be rotating in a circular path around the tooth surface, capturing multiple images at a time. So usually, apart from other techniques, they will have a video format, not in a picture format. So they will capture a video, they will stitch these 2D images into a triangulation or mesh formation to form the 3D model. So this is the clinical workflow. How does in a scanning technique, usually we have to select which company you are choosing as scanner. Is a powder technique or non-powder technique. So the current available scanners are non-powder technique, so no need to apply powder over the tooth surface. So then we have to select which protocol you are going for, the full arch scanning or quadrant scanning. Usually full arch scanning will be done for your full mouth implant restoration, whereas quadrant for your prosthetic or crown and bridges, where sectional scanning also can be done. So once you've done your upper and lower scanning, we'll have a bite restoration. That is how you have a 3D articulation when you do a prosthesis. Then we export the file, that is the STL file, to the lab through the mail or digital platform. So scanning path means how do you scan an arch? Or how do you scan an arch, from where to where you will start scanning and end the scanning. So scanning path differs from different companies. So each company prescribes their own scanning path, how to do and where to do. So one of the most common followed technique is the linear path. So in linear path, what you will do? So we'll start scanning the occlusal surface from one end posterior to other posterior end, then follow the lingual surface, then come to the buccal surface. So usually we will start the scanning from the posterior tooth and from one arch to one arch. From one segment to another segment, we will start from the posterior. It's usually from the occlusal surface, then you go to the lingual surface, then come to the buccal surface. This is a linear path. So other type of scanning will be your closed loop technique. So where you begin, you have to end it. So this is one of the most reliable method because it prevents surface deviations. Because when you start and end in a single point, the accuracy or precision of the scanning will be more enhanced when compared to your full arch scanning. So in case of segmental arch scanning or in case of processes, we will use the closed loop mechanism. The other commonly used technique is your S-shaped or sweep technique, where you will have a zigzag movement. So when you scan a tooth, we'll start with the occlusal, we'll go to the lingual and go to the buccal. Then come to the next tooth, occlusal, lingual, buccal. So this is sweep technique or S-shaped technique or zigzag technique. So this is the common scanning like a pathway adopted by most of the scanners. So we will be having a line demonstration how to do also. I will be explaining in detail. So what are the commercially available scanners? So 3-shape trios, then iTro element, that is your initial scanning, then Medit I70, I700, Dentsply Sirona. So Dentsply was the first to introduce your intraoral scanning way back in 1987 or something like that. So Plan Mica, then Serac system. So coming to accuracy, so how will you define accuracy of a scanning? By two determinants. One is the trueness, another is the precision. Trueness is how the measurement are close to the real value. So if you have a mesodistal width of 8 mm in your cast, if you do a scanning, how the measurements are close to this 8 mm of mesodistal width, okay? That is the trueness. Precision is how repeatable the measurements are. So if you take one time, if the mesodistal is 8 mm, the second time also it should come at 8 mm. There should not be deviations between a first and second measurement. That is your precision. So accuracy is based on both the values, both trueness and precision. You should combine trueness also, that you should give an exact value, and precision where multiple times you take the same scan, you should give an exact value. This is how you calculate accuracy in terms of intraoral scanners. So the scanning accuracy, if you see for a like one of the most commonly used for intraoral scanners is your aligner treatment. If you take for aligner treatment, it should be, the deviation should not extend more than 100 micrometer. So 100 microns they will tell. So any deviations within 100 microns is acceptable for your aligner scanning or aligner therapy. So these are the factors which influence your scanning precision and depth. Coming to the scanner technology, as I told, triangulation, confocal, then wavefront. So most commonly followed techniques, confocal is more precise when compared to the other techniques. Depth and distance. So how much distance the scanning head from your tooth surface, that also plays a major role. So usually it should be between 5 to 10 millimeter. So your scanner tip and the tooth surface should be separated within 10 millimeter distance to get a precise image or precise 3D format. Then comes the scanning area. As I told you, full arch scans are less accurate when compared to the sectional scans or quadrant scanning. So quadrant scanning follows the closed loop technique. Where you begin, you will end there. Then the operator skills. So mostly this scanning can be done within 3 to 5 minutes. So it depends upon the operator skills, how well equipped are they to do a scanning. Then orthodontic attachments, using for the braces patient, there will be a distortion if there is a metal surface during scanning treatment. Then soft tissue, saliva contamination and the soft tissue, free movable soft tissue will be getting a distorted image while doing a scanning. Follow a proper scanning path. So each company like prescribes their own scanning path. You should follow that to have a precision image. So these are the commercially available scanners. So when you're going to practice in your clinical in upcoming years or something like that, so these are the commercially available scanners. So first one is the DEXIS. So DEXIS is basically a US-based scanner. They have a CBCT machine also. They have a RVG. So they are totally into a radiographic examinations in digital format. So it costs around 7.5 lakhs to 13 lakhs from the basic model to the advanced model. Each one has its own advantages and disadvantages. So coming to ITRO scanners. So these ITRO scanners were first launched by Cadent company. So in the year 2006, so they were the first to introduce the interval scanners in 2006. Then around 2008, they were commercially available. So then these ITRO scanners were acquired by Align Technology, that is your Invisalign. So Invisalign company brought this Cadent technology and incorporated the ITRO scanners into closed format. Closed format in the sense, those scans that are taken by ITRO scanners can be only used by the Invisalign treatment planning, not for the, we can't send to other labs. We have to collaborate only with the Invisalign company and do a scanning. So recently, they have broken this stigma. So they have went with the open technique by introducing ITRO Lumina. So previous scanners of ITRO follow the parallel confocal technology, where the current ITRO Lumina scanner follow the multiple direction capture. It captures multiple images at multiple scanner within a time framework. So this is ITRO Lumina scanner. It comes around 20 lakhs. Like this is far most advanced scanner which is currently available in the market. So the main advantage of this scanner is it captures multiple images at multiple sensors. Usually the other scanners will be having one sensor, but ITRO Lumina will be having 4 sensors. So numerous images will be captured at the same time and projected to form a 3D image. So this is how your ITRO Lumina will look like. So apart from gentle scanning, the other advantage of Lumina is it gives a 3D prediction or stimulator. In the sense, like when you do a scanning of a patient, it gives 3 simulations. One simulation is for your prosthetic replacement, how to go about this case by doing a prosthesis. That is your digital smile detailing or giving a implant or doing a bridges or crowns. Second will be your orthodontic treatment. So how can we correct the same patient by using a orthodontic treatment? So this is provided by a stimulator. This stimulator is only available in ITRO till now. So that is why it's too expensive. I'll show you a video of the ITRO Stimulator Pro. So this is how your ITRO Lumina will look like. So basically, along with the chair side, we can do a stimulation and show to the patient and convince the patient for the upcoming treatments. So it provides both prosthetic opinions along with your ortho treatment also. Usually you'll be taking a smile photo up front, then we'll go for the scanning. So this is a software or laptop for the ITRO Lumina. So usually previously scanned images can be uploaded to the photo. This is a scanned image, it will be uploaded. Once the scanned image is sent to the software, the Outcome Stimulator Pro so this is the pre-treatment. The current patient will have an occlusogram also to check the eye points. That is the stimulator. Outcome Stimulator Pro. That if we click that icon, the post-treatment, how the change is going to happen, we can visualize at the same. So these are the features of the iTero. This NRI technology I will show, that is infrared technology to detect the caries. So this iTero is one of the scanner to have this technology. So if you scan an occlusal surface, if the caries is there, it will detect and show us. So this is the pre-treatment. As you see, there is a midline diastema, a spacing between upper anteriors. So having the patient on your chair side, if you show the stimulator, how the post-treatment will look like. So as you uploaded the photo up front, we can see and evaluate the smile correction post-treatment. So there is a gap between the central incisors that has been closed. So once the patient sees the changes upfront, they will be highly motivated through the treatment. So we can convince the patient along the chair side. It's a very useful tool. We can see in the interval scans also, there is a spacing in the upper anteriors. In the post-treatment, the spaces are closed. So this is the Outcome Stimulator Pro by Invisalign. So where you can convince the patient by the chair side, showing the post-treatment records, how your treatment going to happen after a year or so. They will be very much motivated to see the results, and they will be easily convincing for the treatment. So another is your Shining 3D, the oral scan. This is by Unicorn Denmark company. Usually it uses, or in orthodontics, that is your clear aligner therapy, bridges, veneers, all on implants, inlay only, and pediatric dental care. So what are the advantages of intraoral scanning? So enhanced patient comfort. So unlike your conventional impression technique, where in case of special needed patients, where the patient is having high gag reflex or limited mouth opening, intraoral scanners can be very efficient to provide a detailed imaging of the intraoral structures. Reduced operator stress and increased efficiency. So when you prepare a patient for an impression technique, you have to select the tray, and you have to you have to prepare your impression materials. Either it may be alginate or your putty material. Then you have to insert into the patient, wait for the setting time. Whereas the intraoral scanners can be done efficiently within 3 to 5 minutes, reducing the stress and the chair side time also. Improved infection control. So cross infections can be greatly reduced by using intraoral scanners, as we have a multiple scanning tip which can be autoclaved by some companies also. So we can disinfect that easily, whereas your conventional impressions will have a cross infection. They have to pour the impression, they have to send to the lab. There is various levels of cross infections possible by using a conventional impression techniques. Real-time visualization and immediate feedback. In the sense, like if you scan a patient, if there is a defect, on the chair side itself, you can visualize the scan, both in upper lower. Any deficiency can be addressed at the right time. Whereas in impression, if you have a default in impression, you have to pour the impression, the material has to set. Then by the time the patient might gone out of the clinic, again you have to recall the patient. So real-time visualization is possible, and immediate feedback and corrections can be made with your intraoral scanners. So easy retakes and modifications. If you have a defect in normal impressions, you have to repeat the impression. Whereas intraoral scanning, only the segment where you have a defect or deviations, we can scan the particular segment and no need to redo the entire scanning protocol. Efficient data storage and long-time access. As it is a digital, we can store without any space requirement, and we can be accessed at any point of time in the upcoming future. Better clinical analysis and treatment planning. So these intraoral scanners can be incorporated along with the CBCT to assess the bone density, bone level of the patient. Based on this integrations, we can effectively plan the treatment for the patient. Cost and material saving. So when you compare to the conventional technique, you'll have so much to spend on trays, materials, then infection protocols, whereas like intraoral scanners will be less. Remote and rapid communications. So logistics has been greatly improved by intraoral scanners. So if you take an impression, you have to send through courier to the lab or something like that. By intraoral scanners, the 3D data can be transferred within seconds through the mail to the lab. So the real-time production can be start immediately. The same day delivery can be obtained by using this digital format. Advanced diagnosis and treatment planning. So in case of surgicals, we will be discussing about this. In a 3D reconstruction, we can incorporate the intraoral scanners along with the CBCT and form a 3D printed model, and you can plan for the surgery. So coming to our last session, application of intraoral scanners in orthodontics. So it basically will be a repetition from the previous lecture. So indirect bondings. Indirect bonding in the sense like we'll take intraoral scan, we'll do a precise bracket placement based on the tip and talk of the individual tooth. Then we'll fabricate a tray around the 3D model. We'll transfer the tray to the patient mouth and do a bonding technique. That is indirect bonding technique. It is opposed to a conventional bonding technique where intraorally we'll be placing brackets individually. So it offers precise bracket positioning and excellent control of tip and top of your individual tooth movement. So intraoral scanners plays a pivotal role for your indirect bonding technique. And fabrication of removable and functional appliance. So easily you can take a scan, send to the lab, ask them to fabricate a Hollis appliance or any removable appliance. The major advantage will be you will have an excellent adaptation of your palatal surface because of the high precision of your scanning of the intraoral cavity. Then comes your twin block appliance. So this is digital twin block. So earlier when you take a twin block, they will take an impression, they will do a construction bite, they will have a wax bite, then they will be sending to the lab, then they will fabricate. So the advent of IOS like intraoral scans has revolutionized this technique. So you just have to send the scan to the lab. They will do a digital twin block without any lab procedures. So directly you can deliver the patient the appliance over a short period of time. Coming to the digital design of palatal expanders, as I told, we will have an entire palatal surface well captured by intraoral scanning. So the adaptation level will be to a higher precision. So usually when you plan for a implant assisted maxillary expanders, that is your MARP, mini implant assisted rapid palatal expansion. So those cases, your intraoral scans will be integrated along with your CBCT to check the bone level or the depth of the palatal bone. So the portion of the implant will be planned according to the patient's individual patients, and the implant size will be decided following this. So this advent of intraoral scanners along with the CBCT had made the precise position of implants in case of rapid maxillary expansion cases. So apart from this, we have retainers. So as soon as you debond a case, you can send a scan to the lab. They will be fabricating this A6 retainer in the same day. We can deliver the retainer to the patients. Apart from this, we can fabricate other space maintenance and habit breaking appliances also using these scans. Coming to surgical split in orthodontics. So one of the most advanced field is nowadays they are making 3D plates, in the sense like these intraoral scanners along with the CBCT are incorporated into a software to form a 3D model, that is your entire skull. So where your fracture has occurred, what they will do, they will have a ritual appliance. The plates, the surgical plates will be contoured to the patient's surface using the 3D model and delivered to the surgical operative team. So apart from this, if you are doing any orthodontic surgery also, we can plan this virtual osteotomies, your maxillary osteotomies, mandibular osteotomies using the software, and we can fabricate the splint using this technique. So this technique gives you precise position or placement of the splint, so there won't be any deviation, any difficulty during the surgical procedures. So apart from this, we'll have a scanning, interval scanning in cleft lip and cleft palate patients. So when the conventional patient is most hazardous, in the sense like for taking impression in a cleft patient, in case of an infant, the patient should be in a supine position. So we'll be holding the baby upside down, and we'll be taking a impression using a putty impression or whatever it is. So most of the time it will have a gag reflex. The material can block the airway also. So the advent of intraoral scanners has minimized these hazardous events following an impression technique in patient. So where you can scan the patient and send the scan to the lab, where they will be immediately fabricating your NAP appliance, that is nasoalveolar molding. This is the appliance that is used to like constrict your cleft palate or bring the palatal shelves closer before proceeding to a surgical treatment. So for the NAMP technique also, these intraoral scanners plays an important role. So coming to the last topic, the most effective topic. So intraoral scanners are most commonly used, or widely used, or revolutionized your orthodontic principles, orthodontic treatment in the terms of clear aligners. So this is a current era in the field of orthodontics, the clear aligner appliance. So intraoral scanners plays a vital role during your clear aligner treatment. So basically I will rush through. So these clear aligners are basically a plastic material that circles your tooth surface, that applies pressure. It will be sequentially wear by every 1 or 2 weeks interval, so we can get a tooth movement. So the history started from Kessling in 1945, where he formed a vacuum formed retainers as tooth positioning appliance. Then Henry in 1964, he used the Kessling technique to form an appliance that is known as invisibles. So in 1971, Ponds were the first to incorporate this bioacrylic material to form an aligner, that is invisible retainer. So this was used earlier for your bruxism, that is your 9 graininess. In Sweden, 1993 was the first to use this material to align the teeth. So this is the company which is well advocated, formulated right now. It was Align Technology, Invisalign. It was formed in 1994. So it is the current evolution in orthodontics. So every day everything is changing. So in the field of orthodontics also, clear aligners has revolutionized the treatment. So more and more patients are accepting for clear aligners because of the comfort zone and various advantages over your fixed appliance. So basically it's fully automated. As we enter into digital technology, so once you scan and send, we'll process the treatment using a software, we'll plan it and deliver it to the patient. So it's totally automated in a sequential manner, 1, 2, 3. So you have to wear the aligners in a preformed manner. So follow-up and monitoring should be done by the orthodontist at regular intervals to have a successful treatment. So biomechanics, basically it is a pull therapy when you compare to fixed appliance, whereas clear aligners will be a push therapy. It will push the tooth. So basically the clear aligner is a plastic material. It can apply the force and bring the tooth movement. So apart from this, we will have an attachments to guide the complex tooth movements. These are different shapes of the attachments. So how does it work? is basically, as it is a plastic material, it has the elastic property. So when you insert a clear aligner in the crowded tooth, the material becomes elastic, it applies forces and brings the tooth movement. That is how it works. Then comes your case selection. So which model occlusion can be used for clear aligners, you have to decide. So not all the cases are suitable for clear aligners. Certain cases are best done by fixed appliance, certain cases can be easily done by clear aligners. So the patient is suitable for aligners, we have to check, because this is a removable appliance. So only when the patient wears, we can get a treatment. So the patient should be well motivated in order to get a proper effective treatment planning. Then clinician and practitioner are able to handle this case. So most of the cases should be addressed by orthodontists, because like complex cases, complex teeth movements will require the placement of auxiliaries, in the sense like lingual buttons, stats, to perform a complex tooth movement. So orthodontists plays a pivotal role in a clear aligner therapy. So what are the cases can be treated? So as such as your fixed appliance, most of your crowding cases, spacing cases, increased overjet, overbite, open bite and crossbite cases can be treated. Coming to clinical procedures, so you'll have three procedures that is to be performed during your clear aligner therapy, that is your attachment placement, IPR technique and your troubleshooting. So I'm not going to detail about these techniques, I just want to show. So these attachments like composite buttons that are placed on your tooth surface, just like your regular restorative procedure. So attachments are two purpose. They can be either used as a retentive to hold the aligner, then can be used in case of treating complex tooth movement, that is case of rotation uprighting, we need an attachment. So IPR, basically we need space to move the tooth, so space can be provided. So most of the cases in a clinical practice, what patient will be telling, like I won't go for extraction. So most of the cases of clear aligner therapy will go for IPR. So modes of creating space, it can be expansion, extraction or proclination of anterior teeth along with your IPR. So these are the IPR. IPR can be done by this armamentarium. So instructions for a patient, that all clear aligner patient is a removable thing. Only if you wear, the treatment will be effective. So most commonly it will be 20 to 24 hours per day. Then you should follow a proper, only when you brush and eat, you can remove the appliance. So follow up and monitoring, this is where your orthodontist comes to play. Even if you wear an aligner, you should be guided by a proper orthodontist. So as and when, in an interval of 3 months, you should have a regular checkup. We should check whether the treatment is planned and programmed in a sequential manner, whether the aligners are fitting. So what might happen, because we are predicting the treatment at the start of the treatment. So the end result will be predicted during the start of the treatment. We have to proceed to get an effective tooth movement. Patient compliance, most of the case patient won't wear the appliance, so that might end in defective treatment planning. Aligner handling, aligner breakage, complex tooth movement, tight contacts, follow-up and monitoring. So this is the workflow. Usually, this is how your clear aligner treatment goes by. Initial consultation, so you'll check for the patient cooperation, compliance, whether they will motivated for the aligner therapy, because this is a removable appliance. Initially, you'll be taking photographs, both intraoral, extraoral, along with your radiographs. We will be feeding all this data into your software. So then comes your impressions or intraoral scanners, as we discussed earlier. So this is a planning software, aligner planning software. So where we load the intraoral scanners into it, we customize each individual tooth movement. So orthodontist will be playing a pivotal role in planning the case and designing the treatment planning. So each tooth can be moved in 3D and the final portion can be obtained, which can be showed to the patient in case of simulation. So this is the simulation video which we usually show to the patient. So the treatment progress can be directly conveyed to the patient and post-treatment results can be appreciated by the patient by visualization. So post-treatment, what all the changes they expect can be identified or modified or custom made according to the patients. So patient motivation can be greatly enhanced. So this is the 3D printing. As we talked the whole day, this is a 3D printing machine where the resin is poured in a liquid form. The laser will be applied and we will get a 3D models like this. So once you get a 3D model, we will have a vacuum formed machine to place the aligner tray, vacuum pressed on your 3D model to get the aligners. So the aligner materials are basically PETG, that is then polyurethane. Now recently multi-layer materials are available. Then once you finish, you will have a trimming and polishing. This is how you deliver the case. So I have few cases, but I'll skip on this. I'll show a video regarding the aligner lab, so you'll have an idea how does it work, the manufacturing setups. So this is one of my personal case. The patient had a blocked laterals. So we planned for a 2-stage treatment, providing the space for the tooth to come out. So second phase was your molar correction. So basically we went with IPR and digitalization component to provide the space for the blocked laterals to come out. This is in pre and post of this case. இது மட்டும் ப்ளே பண்ணு, இதுங்க ப்ளே பண்ணுங்க, நான் சொல்றேன். So let them have a look. So this is an aligner lab. So basically an aligner manufacturing lab will have the following components. This is the systems which used to integrate the intraoral scanners and do a treatment planning. So this is how they do a pre-design. That is, once you get a scan, this is a laser marking. So 3D printing. So these are the 3D printers where you use a resin to form a 3D models. This is a platform. The resin will be on the bottom. So once the laser pass, it will be cured to get a 3D model. Once 3D printing is done, it is done for curing to strengthen the process. So we will have the accuracy, as I told, we will be constantly checking for the measurements. This is how the aligner is fabricated into 3D model by use of vacuum form. This is an automated machine for vacuum form machine. So per hour we can print around 300 aligners. So usually it contains aligner sheet at the back. So it's fully automated. Once you keep the 3D models, the aligner will be printed and delivered. So we will place a model here. So aligner sheet will be vacuum formed over the model. So thank you for your valuable time. I hope you understand basics about the digital orthodontics. Any questions? So aligner manufacturing la irundhu and scans la irundhu eppadi incorporate panni நம்ம ஆர்த்தோடானிக் பிரின்சிபல்ஸ்ல வேரியஸ் ஃபீல்ட்ஸில் ஆர்த்தோடானிக்ஸில் எப்படி நம்ம யூஸ் பண்ணுறோம்னு சொல்லிட்டு we had a discussion till now. So we'll go on to the intraoral scanning. We'll have a live demo how to proceed for the scanning. So basically this scanner is from Waldent. So what we are using. So before scanning, this is the software which is used by the scanner. As I told, there are three components. First is your handheld camera, that is your scanning wand. Then your laptop along with your software. This is a software which is used to scan, convert the pictures taken by the intraoral camera into a 3D model. So usually for each and every case we have to register like this. Patient name, instruction, for what purpose we are going to do a intraoral scanning. So we have different purposes: restoration, orthodontics and edentulous. So if you go for restorative, you can select the tooth where you want to scan. So you will be having the different options. You are going for the crown or pontic or inlay or onlay. Depending upon your section scan, you can select the option and proceed for the scanning. So as we are going to orthodontics, it will be a full arch scan. So this is the scanning platform. So you have to select which arch you are going to scan. Maybe upper. So once you select the arch, so as you do intraorally, you should follow the regular sterilization protocols. The scanning path. So basically we follow the S-shaped or sweep or zigzag pattern. So occlusion. Faster. when you're scanning for the patient, two main things, like you need to check about the saliva contamination. So any wet fields, it may lead to the distortion of the image, along with your free movable tissues. So your scan should be entirely focusing on the tooth structure. The tissues might lead to distortion. So scanning a patient is a bit tough task, but you can have a try with the models. The stone model, it was not able to capture actually. So this is how we proceed. So occlusal, lingual, buccal. So each two, occlusal, lingual and buccal. So basically this camera captures several images per second. These images are stitched into a 3D projection. The 2D images are stitched to form the 3D structure. So once you scan, you can have a real-time visualization of how the model looks, whether all the regions are covered. So this is the main advantage of intraoral scanner. If any defect is there, you can scan at the particular segment immediately. So as you see, the green images are the structures that are not recorded properly. So we can go to the particular segment and scan, and it will restructure the surface. So as you see, we are starting the scan in the distal of first molar. So where you had the green dots. So you can see so all the structures has been. So you have to just tilt the camera lingually and buccally to capture the entire surface. So once your upper is done, we can go for the lower scanning. You have to just select the lower. So we can proceed for the lower scanning. So lower scanning also, we have to start with the posterior region, occlusal, buccal, lingual and buccal. This is more effective and efficient. And we'll have a greater precision, and the amount of deviations will be less. So as you see, as I take the scanning away from the tissue, the scanning will get stopped. There will be a red mark. So your scanning depth should be always within 10 millimeter. So once I come close to the tooth surface, your scanning will start automatically. So we will start from the posterior segment of one arch to the other. You have to just tilt the camera right and left, so it will capture the whole image. So once you're done with the scanning, you can have a check how the modules are, like model is articulated, any deviations from that. So once the upper and lower is done, we'll go for the occlusion. So occlusion is mandatory for your prosthetic replacement, rehabilitation patient, like just doing a distal articulation. So first you have to choose for left. So basically, you do up down movement. So the left side of occlusion is captured. Then you go for the right one. Just up down movement. So once you finish your upper and lower along with your occlusion right and left, your three models are ready. So this can be sent to the lab or technician within a few seconds or few minutes. So they can start with their fabrication ASAP. So this is how you take an interval scanning. In patients also, we can check for the occlusal high points. That's it. So those who are interested can have a live demo, like they can have an hands-on on the scanner. They can come forward and have a scanning. Any doubts? So this is your 3D model. So you can use this for various purposes as we discussed earlier. Start with your start button. Okay. From posterior. Whichever side. Start. Right. Have the model in your hand. கை தெரியக்கூடாது சரியா ஒரு மாடல் மட்டும் தெரியும் ஸ்டார்ட் பட்டன் so wait okay the green should be displayed okay so occlusal buccal lingual okay each individual tooth occlusal buccal lingual occlusal buccal lingual so try to correlate with the picture which tooth you are scanning okay so once you become so frequent you can just do a scanning within 3 to 5 minutes of time frame. So as you see, once you take this away, there will be a red mark. In the sense like the scanning depth is too much. It should be less than 10 mm. Okay. Bring closer. So if the scanning stops, you should stop your rotation. Okay, as your green visualizes, you're ready to go.
Interested students from Satyabama, Tagore and Ragas can come forward and do the live demonstration.
Good. Press the button again. First button. Yeah. Good man. So you have few artifacts that can be rescanned. Okay. Good. Anyone else? Have the model in your hand. Start with your posterior teeth. Okay. Always it should be like this. Your camera should be like this. Okay. Start this button. Occlusal, lingual, buccal. Zigzag movement. So once every tooth is individually covered, you can proceed for the next tooth. We should not rush. We should allow the camera to capture the picture. Okay, we should give some time for it to capture the picture. Okay. Rotate your cast. Okay. Press the same button, it will stop. You have only few artifacts. So this is a real time. You can check like this. Wherever you want to rescan, you can scan that particular area. Fine. Good. First button. press பண்ணுமா. Keep the camera closer to the tooth surface. Like this, you can't tilt the patient. You remember that, okay? So patient will be stable. Only thing, your camera should tilt, okay? So intraorally, you won't have this. First occlusal, then buccal and lingual. Fine. Yeah. So you have not covered the buccal part. As you see, you have not covered the buccal parts. So usually it should be like this: buccal, lingual. So the anteriors also. See, you are tilting your cast, not your wand. The cast should stay like this. You should, this end should work. Okay. See, you have to visualize there. It's not capturing. If there is a red, you have to stop your scanning and see where it has stopped. Okay. Now slowly move to the buccal. So right hand should work. Okay. Understood? Okay. Stop the thing. Good. You captured everything. Good. Yada? So anyone want to try? போதும் சொல்லிட்டாங்க. சரி, okay. We'll break for lunch. Fine. Thank you.
Thank you, sir, for the insightful lecture and live demonstration of intraoral scanning. We truly appreciate your valuable time and expertise, and we hope everyone has benefited from this session. We thank our respected jury members of the online competitions for their valuable time, expertise, and thoughtful evaluation. Our heartfelt thanks to all the participants, delegates, and guests for your enthusiastic presence and active involvement throughout the program. I would also like to place on record our sincere appreciation for the tireless efforts of the organizing committee and the Department of Orthodontics, whose commitment made this event a success. With this, we formally conclude the program. I request everyone to kindly proceed downstairs for the lunch arranged for you. Thank you. Students of Asan, please stay back for 10 minutes. Students of Asan, please stay back for 10 minutes. 10 minutes.